First of all, welcome. Thank you, everyone, for coming. We were hoping we could fill the auditorium, and sometimes that works and sometimes it doesn't. But the purpose is to really have a meaningful conversation with disciplines that are very experienced in end-of-life issues. Don't have to be an elderly person with a terminal disease or
Hold your mic closer to your mouth.
terminal disease.
It's not on.
It's not on. Because I turned it off again. No, it's not on, Barb.
It's a little touchy.
Yeah, I think I'm not getting anything.
You give her this one.
Yeah, that one definitely.
All right.
Oh, that's live.
That one works, I guess. What we wanted to emphasize is that we're all going to be faced at some point with making end-of-life decisions. Whether you're young with a terminal disease, whether you know somebody that has a serious illness, or maybe you just have somebody who's been in an accident and they're in trouble, and you may have to help make decisions on their behalf. Like to start every meeting with prayer. So I'm going to ask David Lee, who is the minister here at Dover, to just lead us in prayer before we start.
Sure.
Let's bow. Father in heaven, we thank you so much for this day. We know we are dealing with some difficult topics here, but they are topics that we will each face nonetheless. Father, we're so thankful for those who have joined the panel this morning to discuss these things, to enlighten us and help us to learn what to expect and how to handle these difficult things that we will face at some point in time. I ask that you would bless them and bless each of us as we hear and learn today. Keep us safe. We pray this in Jesus' name. Amen.
Okay, let me briefly introduce our panel. The programs have a pretty more detailed biographical sketch, but over at the end to my right is Dr. Kirby Schweitzer, who is a clinical professor of surgery at the Northeastern Ohio Medical University, which I think it just went on. Good? Okay. You probably know that better as Neomed. Most people do. Kirby is an instructor in advanced trauma life support. He's a past instructor of cardiac life support, very instrumental in helping Mercy obtain trauma, which is a level 2.
Level 2, yeah.
Yeah, level 2 trauma center. Kirby also implemented what they call a blood conservation program. So he's very involved in the ethics committee, and that's Kirby. And let Kirby do his own thing when he comes. Next to Kirby is Stephanie Spicer, who holds a master's degree in nursing. She's an adult nurse practitioner. And not Stephanie, that's Stephanie right there. I'm sorry. I thought, wait a minute, that's not right. Yeah. Stephanie has a master's degree in nursing. She's an adult nurse practitioner. She's employed at Mercy as a nurse practitioner in palliative medicine. That's Stephanie. I'll let her, when you want to say anything else about yourself when you present, that's fine. I've got missing a card, which is poor Rachel. Wait a minute. That's okay. No, that's not okay. Rachel is next to Dr. Schweitzer. She has a Bachelor of Science in Nursing. She has a Bachelor's in Philosophy. She also has a Master's in Bioethics. Has spent 9 years in the ICU at Mercy, and also very active in the Ethics Committee. Stephanie, next to Rachel. Has a Master's degree in Nursing, is an adult nurse practitioner, is employed at Mercy as a nurse practitioner in palliative medicine and hospice. So I'll let her take care of that when she gets there. Travis Binwick is a chaplain at Mercy, but he's also the manager of pastoral care. He assists families all the time with advanced directives, filling out durable powers of attorney, living wills, and he has a PowerPoint for you today. There are also handouts in the back if you haven't picked one up, and we're going to let him talk to you about advanced directives. So that's it, and I will turn it over to my panel.
Wow. I don't know if I can stay seated, so I'm going to stand. Can everybody hear me without the microphone? 'Cause I tell you, I will I'll like drop the mic or something. I apologize in advance to the other panelists. I may steal some of their thunder. So I'd like to get an idea. How many here are like professional in medicine? Anybody? Okay, a couple people. Community? Everybody's in part of the community, right? So, and can I have a couple of you just tell me why you're here? Anybody?
My husband on stage 4 echo.
Okay, so you're going through this at the present time. These questions and everything. Anybody else? Because you're old. Yeah. No one gets out of this life without facing death. So one of the aspects of this is that I'm a physician, and I am taught all through medical school, all through my residency, my practice of almost 40 years is, to relieve pain, suffering, to prolong life, to cure disease. Part of that process has to deal with dying, unfortunately. Everybody's going to face it. And when you talk to people that haven't really thought about or have thought about, the theory or the thought comes up is, what is a good death? And in this country, in our society, we really don't have a good feel for that. Our whole society is centered around the aspect of youth, beauty, vitality. No one really talks about on commercials, have a Budweiser before you die. No one talks about it. It's, let's go party, let's go do this, let's enjoy life. And that's part of it. We should enjoy life. But we also have to face the fact that people are going to die. So, when I'm dealing with patients, what are some of my goals? My goals are, one, how can I help control pain? How can I make the patient comfortable? How can I deal with some of the other physical symptoms? Maybe even, I'm sure Rachel will talk about getting people up out of bed, taking in, what do you enjoy? What kind of music? That sort of thing. I think also what I try to do when some of my patients are facing death is try to involve people that are important to them. One of the saddest things that I see happening in some of my patients is loneliness. They don't have that support system. They don't have someone there that they can talk to. Their power of attorney is their son that lives in Florida and that hasn't seen him in 5 years. It's a very sad thing. So, but who in that person's life is important? How can you get those people involved with them? I think the other thing is, and I don't know if anybody's going to cover the stages of grief and things like that, but people that having terminal, yes, you are?
Oh, yeah.
Okay, good. Okay, I'll skip that part. But people have to come, that go through a diagnosis that is devastating or terminal, go through stages of grief. And one of those things that I think that I can help with as a physician is acceptance. What are our options? Where are we heading? What do you want? And those are very difficult subjects sometimes. And it's very easy, especially in the pressures of modern day medicine. You've got X amount of people to see, you've got so much time to see them in, you've got a computer system that is like an octopus. It's, the tentacles are in every aspect. And you spend more time on the computer than you do with the patient. It's a sad commentary, but it's the reality of life in medicine these days. But how can you take and bring that person through the stages and not like what is going on, but accept what is going on and within those parameters, proceed with what is left of their life in a fashion that is acceptable to them, in the way they want it. Another thing I look at as a physician dealing with patients that are dying is medical understanding. I think patients and their families look to caregivers, nurses, doctors, everybody that's part of the team, to educate them about what's going on, what are my options, what are the benefits and risks of those options. Sometimes we face situations where the cure may be worse than the disease, and you have to weigh all that. And the other thing that happens is, what may be important to me, what may be acceptable to me, may not be acceptable to my patient or their family. And so you have to be sensitive a little bit to that aspect. And I think the other aspect that I look at on patients that are dying, my patients, and I am board certified colorectal surgeon, and I have patients that unfortunately don't survive the disease, is to be a guide, to be someone that can help a person and that family walk through this maybe dark place, maybe this woods, maybe this area that they don't understand, and kind of guide them through some of these challenges they're facing and some of these aspects of, where do I go from here? What do I do? Those are questions. So, how do we do that? Well, it's not easy sometimes. I deal with trauma. I am a trauma surgeon. I also am a colorectal surgeon, so I have both sides. I have patients that have a devastating disease and maybe beyond what I can do. I have patients that come in unexpectedly dying. Remember when I was in medical school almost 40 years ago, I was on internal medicine rotation, and my attending was an oncologist, Dr. Mary Smith. And through this third year of medical school where you're in the hospital, I've seen people die. People don't make it through a code, but you don't have a connection. So there's one very old lady who was dying of lymphoma, and she was in the hospital, and she was not going to make it, and she understood that, and she was kind of alone. She really didn't have close family. She came from a nursing home, and Dr. Smith asked me one night, I was on call with residents, says, don't worry about what's going on with the service. Don't worry about following the resident around like, we're like little puppies, medical students sometimes, trying to figure out what's going on, what am I supposed to do, what do I need to know. She said, I want you to just take a couple hours and I want you to sit by Mrs. So-and-so's bed and just observe. Just be there. And I was like, man, this is a waste of my time. I should be studying. I should be gone out seeing this patient in the ED that's in congestive heart failure. I should be doing this or that. So I said, okay, this is what she wants me to do. She's my attending. I'm going to do it. So I went in. The room was kind of dark, and she was breathing and kind of asleep. And I sat down, and I watched. And I watched. After a while, she woke up and asked me for a glass of water or a drink of water. And I got it for her. And she could hardly even sip out of the straw. And as I was getting this water, I sat back down. I reached down, and I inadvertently, not on purpose, touched her hand. And it was cold. And I sat there, and I scooted my chair over, and I just held her hand. And she looked over at me and smiled. And we didn't really converse. The breathing got slower, more erratic. Towards the end, she was almost gasping, but she was comfortable. And she died. And that was the first time that wasn't in an emergency, that wasn't in a rush, that I experienced someone pass, going from a transition from this life to the next. Sometimes that's the way death is. You have the opposite extreme. A few years ago, we had a 6-year-old boy come into our trauma bay who was playing with a gun with a 12-year-old neighbor and got shot in the chest. And according to the squad that came in, they gave a report that he still had a pulse and was breathing at the scene and on the way in. He wasn't done at that time, but we said, well, if this is witnessed, maybe we can save this little boy, 6 years old, about this big. And all I could see was, my grandson, laying on a gurney, bleeding out of his chest. And we did something that we do very rarely, because it's kind of like the end. It's the last thing you do. We opened his chest. And by this time, the cardiothoracic surgeon had come down, and there was a flaccid heart. There was no blood in the heart, despite pouring blood into him, fluids into him, and he died. And, that's a sudden, unexpected death. Happens often in trauma. You don't expect to get in a car wreck and end up dying. You don't expect to get shot and end up dying. You don't expect these things, but they happen. How do you talk to the parents? How do you tell a mother who is wailing that her son is gone? Very difficult. So when we start to prepare, we start to think about death, we start to think about the end, there are certain things we can do, and certain things that need to be done. One of the aspects is talk to those important to you. Make sure they understand what you want. My father died 7 years ago. Before that, 4 years before that, he fell and had traumatic brain injury. So he was slowly going downhill. But when he was still with it, when he could still communicate, we had some tough conversations. He told me, he said, don't want a feeding tube. Don't want resuscitated. He was ready. He had a good relationship with God, and he said, I'm ready, I'm done. And so when the time came, we had hospice involved with both my father and mother. When the time came, he passed. He passed with all of us there in the house. My sisters couldn't stand to be beside him for some reason, which is not an unusual feeling or response. But I was. And he died. But he knew what he wanted. More importantly, he knew what he didn't want. And he was prepared. And it made it easy. Not so much on him, possibly, but on the family for sure. My mother was the same way. She died a year ago. And she had everything ready. All the burial arrangements, knew what she wanted, knew she didn't want resuscitated, knew she didn't want to go to the hospital, that sort of thing. So she died. My sisters and I were meeting with the funeral director, and the funeral director had us come in. He said it'll take 2 or 3 hours. Go through all the stuff that we need to do for funeral arrangements and everything else. I said, man, that seems like a long time. Ours was 40 minutes. Because, we went down the list. Well, what about that? Well, Mom already took care of that. Well, what about this? Well, she decided this. The biggest decision we had to make was, Mom couldn't decide one of 3 dresses that she wanted to be buried in. And so I looked at my sisters and I said, hey guys, that's your ball game. That's not mine. You pick which one you want her buried in. But it was nice because it was ready. She was prepared. What happens when you're not prepared? Some real disasters. Sometimes this is where the ethics come in. Okay, so be careful who you have for your power of attorney. If you don't have one, the state will assign one. Okay? There's a whole set of laws and rules. Am I stepping on anybody's toes here? Okay, the whole, all yours? Okay.
Don't worry about it.
Okay, there's a whole set of laws and rules, but just be careful who you have. So, a few years ago, we had a situation where even though the situation with the patient was terrible, terminal, was not going to survive, we have such great technology now that it used to be 100 years ago what people die from. Infections, right? Sepsis. Didn't have antibiotics. You know, you got sick. You either got the disease and you survived or you didn't. And that was the number 1 cause of death 100 years ago, was infections. What's it today? Neoplasms, degeneration diseases, man-made diseases, smoking and drinking and drugs. What do we, it's shifted. So you can keep someone alive for a long time. When I started my medical practice 30 years ago, what did people die from? Heart failure, cardiac issues, respiratory failure. Now we're so good, we can keep that heart going a long, long time. We can keep those lungs breathing on the machine a long, long time. So what do they die from? Well, they do die, but now it's oftentimes necrosis of the bowel. Because the heart and lungs are still okay, but the body's dying. Dies from something. So we're keeping this person alive, this patient alive, and even though it was a situation where there was no hope, the family kept insisting that we do everything. Kept insisting, you probably remember this case, kept insisting to do everything, insisting that we do everything, insisting we do everything. It was terrible. It was a terrible situation because when I view a patient that is dying, I view very simplistic. I'm a surgeon. Things have to be very simple for me, okay? They can't be complex. So, at what point do you stop prolonging life and you start prolonging death? And that is a difficult thing, and it may be different for everybody. For someone with this religion, may be different with this family background, with their experience, than someone else. But at some point, you have to look at with medical technology that we're not helping this patient. We're torturing this patient. We're prolonging death, not prolonging life. And that is a decision that has to be thought about beforehand. So, to make a long story short, after I think it was several weeks, 3-4 weeks, wasn't it? I don't remember. You remember the case, I think. We found out that, as long as this person was alive, family kept getting Social Security checks. And besides that, they were living in the house. They would lose the house. That's a tough ethical. You say, well, that's terrible. But think about the family. They're going to be put out on the street. How do you judge? Keep grandpa alive a little bit longer or have my kids out on the street homeless? These are tough things. These are tough ethical decisions. So I think I'm going to close up here because I've got way too much to do. And I think the one thing I did want to bring out was some of the end-of-life ethical issues that I think we face as a medical profession and helping families go through this. One I think is one that just sticks out is communication, broken communication. We have a terrible problem if we don't communicate. And sometimes I communicate up here, and I need to communicate down here. And I need families that are willing to say, wait a second, I don't understand. I need help with this. Okay, so broken communication between the caregiver team, between the caregivers and the patient, and between the caregivers, the patient, and the family. I think that's one of the big ethical issues that I see over the last 30 years of my practice. The second one is compromised patient autonomy. So, you know, the government has to get in everything. So a few years ago, they passed the Patient Self-Determination Act. That's where HIPAA came in and all this stuff. And the thought was very good, and I think it is very good, the concept. But as someone comes towards the end of life, they start losing their autonomy. Most of the time. Sometimes not. Sometimes it's a physical, not a mental thing. But that is another ethical issue. What do you do with a person who hasn't made these decisions, who's losing their autonomy, or who we put in a situation where they lose the ability to self-determine what they want? I think the third thing is, and this is rests a lot on the medical management, is poor symptom management. You know, how do we deal with your symptoms in a way that is ethical and is tender, is something that you would want? I think of the golden rule. How would I treat this patient is how I would want to be treated. And if you're in pain, what do I do? Well, you have to weigh the risk and benefit ratio. Okay, so I can give narcotics, I can give a lot of pain medication, but I may cause you to stop breathing soon. So is that an ethical choice? Is that a choice I want to be able to make? These are things you have to balance. And it's so helpful if the family has had this discussion and they say, Grandpa wouldn't want to live this way, or my dad wouldn't want to live this way. You know, let's make him comfortable. Let's put him on a morphine drip. Let's do what we need to do. Oh, well, you know, that's going to make him stop breathing. Well, that's fine. We also have the issue in this symptom management aspect is not starting or withdrawing care. To me, medically, ethically, and from a treatment-wise, withdrawing care is the same as not starting care. But a lot of people don't view it that way. They view it, hey, he's on the ventilator, we can't stop the ventilator. Or he's on a feeding tube, we can't stop that, we've started it. That's not true. You can always withdraw care. I personally rather start something and withdraw it than not start it and then have second thoughts, maybe we should have. Okay, so that's one of the other issues. And then I think the other end-of-life ethical issue that happens is the aspect of breakdown of shared decision-making. So we know that people have autonomy. They can make decisions. But really, we as caregiving team have a huge aspect, huge situation, where we can kind of direct that. I talked earlier about being a guide. I think that's really important. We need to guide people through this. We see it, unfortunately. We've seen it many times. We've been there, not personally, but we've been there. A lot of times it's the first time the family, this patient, is facing this. And so one of the ethical issues that we can see break down is this shared decision making. You know, what's the communication? Especially if you have a family that disagrees. You know, we should be doing this. No, we should be doing this. No, we should be doing this. Well, you're the power of attorney. You have to decide. Well, I can't decide because my sister doesn't want me to do that. that sort of thing. It's this breakdown of shared communication, decision making. That those are the kind of things, thinking over this presentation, this talk, that I was thinking, where are the breakdowns of these things? And these are the things that I've come up with. So I'm going to stop at this point because I'm already 5 minutes past my time, and I'm going to let someone else take over. So thank you for your attention.
Doing questions?
Are we doing questions, or are we going to do at the end?
Whatever you want, it's up to you. I mean, if you want to give some questions now, if there are, that's fine.
That's fine. Anybody have any questions for what I covered? Yes.
Feeding tube.
Feeding tubes, yes.
My mother died in West Virginia.
Mm-hmm.
They said if we started a feeding tube, we had to have the hospital's permission, the nurse's permission, the doctor's permission, everyone had to give consent. It couldn't be withdrawn. Now, I don't know if that's true here or not, but
Every state has different laws, and I can tell you in the state of Ohio, it is not. And as far as I know, most states don't have that issue. When you have the issue with withdrawing care, it's because there's division in the family. So the family says, yes, I want it, no, I don't. And then the physicians are saying, well, what am I supposed to do? They can influence that a little bit by saying, this is the end. We don't need to do this. So we can stop the tube feeds. We can do whatever the feeding tube is. So in West Virginia, I'm not sure what the laws are, but I'm pretty sure that the person who is in charge, who is responsible, who is the power of attorney, which we're going to get to a little bit later, can make those decisions. And the only problem is when you have two interested parties, brother, sister, whatever, and then you can get the legal aspect involved. We think about the Karen Ann Quinlan case, where the husband and the parents couldn't agree, and then it just keeps winding up and goes from court to court and all this stuff. But that, as far as I know, is not true. But I don't know what it is in West Virginia. I don't practice in West Virginia.
In some states, I know that so if the patient already decided on something, that you have to carry that through. But Dr. Schweitzer's right in the sense that I would think that any state would have the provision that if it was no longer medically appropriate to feed the patient, because feeding we think is essential, but at some point it becomes contradictory, like not helpful for the patient anymore because it causes problems because they're not meant to eat anymore. So usually,
that's with my dad, they told us if we fed it, well, both of them, if we introduced a feeding tube and his body was shutting down, it only complicated and made him more uncomfortable. That's true.
It can be, yeah, in certain
So you're
circumstances.
not starving them, you're actually just allowing
Yes.
nature's course.
Yeah. My dad quit eating. He just was done, and then he quit drinking, and then he died, and I think that's one of the aspects of, Any other questions, comments? Yes.
That's a real practical question, Dr. Schweitzer. If I'm a family member in a situation like that, what's the best way to get a hold of the doctor? Do I make an appointment? Do I try to be there when you round?
The easiest way is try to be there when I round, but that doesn't always happen. So I've been called multiple times by nurses. I try to take numbers. I've given families my number to reach me. They can reach me through the office, but that may take a day or two because if it's not urgent, the office staff is told not to call me unless it's urgent, because otherwise, you just get called all the time. So, but I think the easiest way to do it is talk to the bedside nurse and have them communicate with the physician, and different physicians round at different times, and unless you have an emergency or something, I'm pretty consistent in rounding. So I think the easiest way is that way. I think you can also call and make an appointment. The problem with that is that I'm booked out, like myself, like 2 to 3 months. So it's a long time, so you want something addressed in the next day or so, that's not gonna work. So I think the best thing is to talk to the bedside nurse. The nurse can contact me at any time. I'm usually pretty responsive to patients and families. And then I think also the aspect of family meetings. We don't do that enough, where we have caregivers and families all come together and they talk. I pretty much insist on one person being the contact person. Because otherwise, you know, you have Sister Susie and Brother John and cousin so-and-so all calling you, all wanting all the same information. So if we have one person that can be the contact point, that's the easiest way to communicate. But communication is tough. We're all busy. Everybody is running around. Everybody has multiple patients. It's very difficult, and I think that's one of the, I said, ethical issues that we have is communication, breakdown in communication. Anything else? Okay. You're up.
I'll try to use this, but first, just a little bit about myself. I got my bachelor's in philosophy in 2006, and then I headed straight into a master's program in bioethics. And I mention this because I think that's where my passion really came from for end-of-life care, and decision-making really started to take shape. All the elective courses I took during my bioethics education was somehow connected to death and dying. I took actually a semester of my master's program. I went over to the Netherlands and studied physician-assisted suicide. So I've seen it from the philosophical point of view, and I spent a lot of time in the hospitals doing rounds with the ethics committee up in Cleveland. And that's where I knew that my place was going to be inside hospitals working directly with patients. So I went back to nursing school and completed my degree, and I started in 2011 at Mercy. I spent 2 years on like a med-surg unit where I quickly realized that situations that many nurses kind of shy away from or run away from, I would run towards. And so I found my home in critical care nursing, and I've been there, except for 1 year I left to work in a pain management clinic, but I've spent the last decade working in critical care with the sickest and most vulnerable patients in the hospital. So when Kay asked me to speak today, I was kind of like, what does she think I have to say on this subject? But anyone who knows me knows I definitely have a lot of opinions on the subject as well. So I guess I'll just kind of share some of the experiences I've seen in the hospital, because, and we got a glimpse at that from what Dr. Schweitzer had to say about the difference, I think, when he shared about his parents passing versus some of the things that I see. And we're really pushing people today to think about, what do you want the end of your life to look like? So, yes, we live in a time where our medical knowledge and technology is so advanced, but I think that our thinking about these technologies is far behind the actual technologies we're using. So, the hard part for me as a nurse is the in-between. It's not the death and dying. You know, Dr. Schweitzer talked about sitting with that patient and watching her last moments. To me, those aren't the hard moments. It's the patient where the do everything takes over from the families, and we see so many machines and tubes and lines that they don't even look human anymore. especially in the cases where we, as the healthcare professionals, know that the condition is hopeless, and that the treatment is what we've said is futile. And yet, the family insists that we continue to do everything. That really is the hardest part of my job, and I think that that's what brings me here to speak about that. I have 10 years of stories of patients that would keep me up at night, you know. Dr. Schweitzer was mentioning one of them. I think that's the first one on my list, actually. The details of that case for me that stood out was that this was a 90-something-year-old patient, and the daughter decided to trach and peg him, where is a surgical incision in the neck. He was hooked to a ventilator, surgical inserted feeding tube, and I said to her one time, I said, he's 95, like how long do you want him to live? And she said, my dad's a fighter and he has a lot of life left to live. And I was like, what does that life look like though? Is that a life that he would want to live? You know, that needs to be the question. We're not asking like, do you want your family member to die? Absolutely not. Nobody wants to leave this earth, but we're all going to do it someday, and what that looks like is a question for the actual person that's going to have to experience it. I think of a man that was in his 60s and he was dying of heart failure, and the medicines were no longer working. He didn't have any surgical options, and his doctors told him that he could die any day from sudden cardiac arrest. And when I was alone with him in the room, he would tell me like he just wanted to go to hospice and spend time with his family, and then the family would come and they didn't want to hear it. You know, they kept saying, oh, you're gonna fight this, you're gonna get over this. And they just would not accept what he knew and had accepted was happening to him in his body. And so I tried to speak for him and advocate for him about hospice and respecting his wishes. And I came in the next day and his family had asked that I be removed from his case. And they continued with his aggressive treatment, and he ended up staying in the hospital, I think another month, and he had a cardiac arrest during dialysis. And so that's how he spent the last month of his life. And I think it's partly because he didn't want to disappoint them. And again, a breakdown of that communication. What do we want? What do we value? These end-of-life decisions don't always have to be morbid. Sometimes it really is a reflection on our lives and what's important to us and how it changes over time as we age. Yeah. So I think many of the conversations I've personally had with families where they're trying to decide between comfort care and continuing aggressive treatment, I've literally asked people, because I try to bring the focus back to what would this person want that you're speaking for. Would they want to be hooked to machines, bedbound in a nursing home? And I know it's a harsh thing to say, but I think that the reality that they may find themselves in is harsher than I'm even describing in that brief statement. I think it's natural that as a society, we tend to avoid the topic of death, or even dismiss it, because, you know, we don't want to be negative. We want to focus on the positive. But we're all going to die. And because of our own discomfort with disease, death, and dying, one of two things happens. And you talked about this as well. We avoid the sick altogether, or we dance around the topic. And that's very isolating and lonely if we don't have the people that we love and trust and care for as people that we can talk to about what's going on. And I'm a fixer. I like to fix things, and it's not a comfortable situation when you're powerless over the disease or the progression of disease. So I find myself in those situations that I like to call it a life in review. Letting them share the stories and things that meant something to them, just to listen to anything that they may be experiencing or going through, so that they know that they're still here, that their life matters, who it matters to, you know. That becomes my focus when I'm dealing with patients who are dying. And I encourage families to do the same, because how many times I've come into a room and everyone's sitting there silent and uncomfortable and walking on eggshells because nobody knows what to say, because the impending doom that they're feeling about losing someone that they care about is just crippling. And while I understand that, those precious moments that are left are, sorry, this is a harsh thing to say, but I can't think of a better way to describe it. It's a waste, you know, and so I'll start asking questions just to encourage them to talk and laugh together and be together. They start telling stories about the person that's laying sick in the bed, and everybody's laughing and smiling, remembering. And that's not a betrayal of the person whose life is hanging in the balance, you know, the in-between time. It's honoring that person. And if we can remember that and have these discussions while life is well and good, then it won't be so uncomfortable and isolating when the time comes. And it will come for all of us. Sometimes there's warning and sometimes there's trauma, but you know, you don't know how much time you have left. And then the other piece, so you know, you've done your walk down memory lane, what do you do now? And I say, well, tell them about your day. You know, you are the people that are important to your loved ones. Share with them. They would want your life to continue. Share the pictures and the stories, or the funny thing that, you know, the niece, nephew, grandchild had to say today. So that's the kind of approach that I've taken as the bedside nurse in actually dealing with families who have a loved one dying in the ICU. Like I said, the conversation needs to come before then. So in my own family, it's often a lighter discussion. It's what do we value about this life? What makes us happy? What do we enjoy? And I think over time, with aging, my parents have noticed, you know, that changed, and they grieve the loss of things like eyesight and not being able to drive anymore for my grandparents, and you know, having those discussions of loss and physically what they're experiencing inside their bodies, and that has helped me to know when it comes their time what decisions I will make for them, because you know, you have a nurse in the family, they often become the durable power of attorney. Yeah, so don't have the conversation once. You have it over and over again as you age and change and redefine who you are and what matters to you. So the last kind of piece I want to talk about is the do everything. As a reminder that it's not the only option. It doesn't have to be the way that life comes to an end. Some of those stories I was talking about it doesn't have to look like that. With the diagnosis of disease, I think of the cancers, COPD, diabetes, dementia, heart failure, high blood pressure, strokes. Once diagnosed, you know, the first thing that doctors want to talk about is the treatment of the disease. Of course. But what does progression of the disease look like? That's always my question, and when I'm involved in the family meetings that Dr. Schweitzer talked about, that's kind of what I urge physicians to talk about, because they're fixers too. Maybe even more so than the nurses. So if you can't cure it, what is it going to look like as it goes along? Let's not just talk about the right here, right now, but where does it go from here? So as patients come to the hospital, they bring with them their pre-existing conditions, and making medical decisions needs to take this into account. The biggest mistake I see families make, they make comments like, but he was fine before he came to the hospital. And he's got a list of comorbidities and medications a mile long. Like, was he? He had a life that was enjoyable, or her, of course, was enjoyable and gave meaning to the patient. But now we've reached the progression of everything that was under the surface all along. So what do we do? And the three options are: one, full code, do everything. That's all that invasive kind of equipment that I talked about. It's the CPR. Option two is the DNR comfort care arrest. That's the keep doing everything, but if my heart goes into like a lethal arrhythmia, something like the VTAC, VFib, you see on hospitals, or on TV, they pull out the paddles and shock the rhythm. That's the lethal arrhythmias. So at that point, we shift our focus to comfort care only. How can we allow this person to be comfortable instead of CPR, which is just it's brutal. You know, I don't know how many codes I've participated in over the years, and I've performed CPR in the community as well. It's not that I'm anti-CPR.
I'm glad you clarified that.
Yeah. The
If I
CPR.
drop here, please do CPR.
Got it. The CPR I did in the community, one was on a child who was probably about 2 years old that had drowned in the pool. And he lived because of that CPR. It's life-saving. I am for saving lives. I also did CPR on someone at the YMCA. He was in his 60s and he just dropped like on a weight machine. And I shocked him and he went to the hospital, and I got to meet with him 6 months later to talk about his experience and all that. Because after I did the CPR, he woke up and he was like, "Don't hurt me," because it's painful. You know, ribs break. The shock itself feels like a horse kick to the chest. So I guess my point is that yes, this can be life-saving measures, but if you're bringing with you this laundry list of comorbidities, your chances of having these types of survivals I just described becomes less and less. And I'm not saying don't do it, I'm saying it needs to be taken into consideration. And each person needs to make that decision for his or herself. The final option is the DNR comfort care only. Sometimes I've seen that go into effect too after we have done some invasive things. So it's more like the withdrawal of care. We take them off the ventilator kind of situation, and we shift our focus. One of the doctors I work with in the ICU, Dr. Botros, I heard him use this line with a family, and it stuck with me as the best description of DNR comfort care. And that's that we're gonna not stop treating the patient. We shift our focus from aggressive treatment to curative treatment, and we now focus on the patient's comfort. And so instead of treating numbers on our monitors and our machines and our lab work, we look only at our patient and say, how can we help control the symptoms as they near the end of their life and maximize the quality? There's a lot of medications. I think our favorite often is the morphine, because in addition to treating pain, it also, that gasping that Dr. Schweitzer was saying about the woman he witnessed in med school or residency, that morphine helps with any sort of what we call air hunger. And I bet Stephanie will mention some of those kind of things. I always love to see when Stephanie arrives at the hospital and helps to make sure that the symptoms are managed. We can't always guarantee the outcomes we want to see, and that is, our patients returning to the life that they had before they met us. But we can guarantee comfort. So the last thing I'll end with is a quote from, and I've loved her since grad school, is Dame Cicely Saunders, who is not only a famous nurse, but also a medical social worker, a physician, and a writer. She dedicated her life to the welfare of terminally ill and dying people and laid the foundation for the modern hospice movement. And she said, "You matter because you are you, and you matter to the last moment of your life, and we will do all we can to make that life as good as we can." And so that really sums it up for me of why I do this. I want it to help people to live the best life that they can, and as defined by the person I'm helping treat. So that's all I have, if anyone has any questions for me.
I've preached for 60 years, so I got a little experience with hospitals and dying. And one of the things that a patient shared with me who had cancer, everybody avoids me like I'm going to spread it to them.
Yeah,
And all I want is to feel normal.
yeah,
And I think you really brought that out. It's not things that make us happy, it's our experiences.
yeah.
So sharing their life, I really appreciate your work.
Thank you. Yes.
You spoke of using morphine as a comfort for this time. But I have come to see what I feel is overdue, to where the patients just checked out from locally, and I mean this world, but they're between here and their next destination, and they're just lying there with their tongue hanging out their mouth, breathing. If they open their eyes, they're like, what, roll back in their head. So I don't know how I feel about the morphine, part of that. I've come up against that now once medically, and you know, the doctor's looking at me as if, you know, when you're telling me how to do my job? Yeah, because I see where this is way too much. And it really were at the time, it really were. So, when you have that situation, what's the approach?
Yeah, and I've had this discussion many times with families. I know the situation, I can picture it. And Dr. Schweitzer said this as well. It is a trade-off that needs to be. I involve the family in my treatment of symptoms. And the morphine, yes, it will, as a side effect of the medication, make people drowsy at times. So we do have to find a balance in the dosage of that. But when we're talking about the very, very end, the alternative to not using morphine is often worse. It's yeah. I've had other family members tell me of previous experiences they had without the morphine, and they witness a person who is gasping, and we call it guppy breathing, like snoring, it's fighting, it's ugly. And so I'm not afraid to use morphine. I always say that when it gets to that late stage, I want it to look peaceful. I'm not going to do it to snuff out a life that's laying in that bed. I want them to appear peaceful and almost like they're sleeping or dreaming. If I see them snoring and gasping and struggling, that's when the doses of morphine come in. But the trade-off is that, yes, the conversation piece of end of life is now over. We've reached that next stage or phase of the death and dying process. I don't know if that answers your question, but
I think this goes back to one of the aspects about communication, and this is where I know Stephanie's going to talk about hospice. That's where the hospice nurses are unbelievable good at what they do, and it's not just the physicians. The physicians have to write the order, but it's also the determination of those nurses that are trained and experienced. And I'm sorry that you've gone through the aspect where maybe a little bit too much was given. It's not just morphine. It's all kinds of opioids, all kinds of other drugs that can be helpful. But with anything, it's a double-edged sword. So you have to weigh the pros and the cons. And again, that communication is the key. You've got to be able to communicate with the nurses, with your care team, with your physicians, and they have to be receptive to that communication. If they're not, then that's more of a difficult situation, and maybe a situation where you need to look at who is treating and who is in control. I know there's some physicians that are very paternalistic. They say, what I say is the way it is, and there's no give or take. And that's not true in life or in medicine, so that's why it's called the practice of medicine.
And I would encourage you to think about the fact that, from our perspective, the disease is causing the death of the individual. Morphine is added to ease those symptoms as that natural process happens. So what you were describing that you saw in that patient is a natural progression of illness. Illness causes decrease in level of consciousness and changes over time. Normally, we only use the morphine and Ativan when there's not a national shortage to ease those symptoms. I have been in a situation where, because I prescribe morphine quite a bit in my practice because I specialize in end of life. I've been in a situation where something like that occurred and I offered to pull back on those doses to see what then happens with the patient. Almost all of the time, what ends up happening is that patient becomes uncomfortable again. They start breathing too fast and their heart rate goes too fast, or they start getting restless. So the family then sees, and I can see then too, that we are treating the symptoms of the decline. We're not causing the decline. So you're up. All right. So now I'll tell you that my name is Stephanie Spicer. So I'm going to stand up just so I can see people. So I'm Stephanie Spicer. I'm a nurse practitioner. So like Rachel, I started somewhere else and ended up in nursing. I got my degree in psychology from the University of Wisconsin-Eau Claire in 1992. So along with that, somewhere around 1990, when I was just about to graduate 12 credits later, I decided that I didn't want to go to grad school for psychology anymore. So I said, well, you know, we have a nursing program here. And I saw that the nurses got practical experience doing certain things. And so after 4.5 years of college, I added nursing and graduated another 2 years later. So I became a nurse, worked in the field for a little while in Milwaukee, and then decided that bedside nursing was very busy and perhaps I could fit elsewhere on the team. Decided to get my master's degree as a nurse practitioner. In the meantime, I had moved to Ohio. Actually, I lived in New Philly when I first moved here. A couple of different things, including palliative care and hospice, and I'm going to start with the stages of grief. So Dr. Schweitzer talked a little bit about the concept of the stages of grief. These stages are can describe more things than just grief when it comes to loss of a loved one, loss of your health. It's loss of anything. On the way up here, I was thinking about different things, any type of loss over time, the fact that we're aging. For instance, when I first got a gray hair at the age of 18, I was in denial. That can't be a gray hair, right? I'm only 18, right? And then when I got to be about 30 and people were noticing my gray hair, I became a little bit angry about it. So, and over the years, of course, I've come to acceptance. No more color, it just is out there. So the stages of grief are, like I said, universal for anybody who goes through a loss of something. We talk about it a lot in terms of loss of a loved one. Denial just means that you're having trouble accepting that this is what's really happening. It can be on behalf of the person who is going through the health event. It can be on behalf of the loved ones who are watching that patient go through that. But denial is, in general, having trouble coming to terms with what is. Anger is when you realize it is really true, and then feeling like you're being punished, or it isn't fair, I have all these things that I still need to do, I didn't even make my will yet, and I have a lot of things to do before this happens. So we all have our lists of things that we need to do, and when you find out that perhaps your time is limited, it can be frustrating. Bargaining is when you try to make some people bargain with their creator. You know, if I do this, can I have a little bit of time? If I decide to not drink alcohol anymore, will everything get better? So that's, you bargain with your creator, you bargain with yourself on how you're going to act, and then perhaps maybe things will turn out better in the end. Depression is when you just can't even, when you don't even know what the next step is to take, when it just overwhelms you and you don't know what to do. And then acceptance is when you come to the knowledge of what is, and you can constructively deal with what's happening. And again, that's all these stages are for any loss in your life, any changes in your health, and can happen on behalf of the person it's happening to or the people that are around you. The other thing is that the stages don't always go in order. Sometimes you can skip from one to the other. When I think it's Elizabeth Kubler-Ross came out with these, generally people go through them in order, but not always. You can backslide, you can find out something new about your health and go back into denial. It depends on, your personality and the event that you're going through. So, am I making a lot of noise? So, because we all go through stages of dealing with loss of health, changes in health, disease issues, we have developed specialties that deal with end-of-life situations. I think that the specialties are even more important because, like these two mentioned, we have so many medical interventions at our disposal at this point, so many more than 30 years ago when I started working in the medical field. I think it used to be very much more clear. We don't have anything else we can do. But I think at this point, most medical professionals have trouble saying that. It's more like, we have a lot of things that we can do, but we're gonna talk to you about whether or not we should go forward with some of those things. So, along with that, I wanted to make a comment about a term that these two used that I don't like at all. So, one of the terms that they used that I try to avoid using is the term withdrawal of care. And I know they've probably heard me say this before actually, because I don't like to say that we are ever going to withdraw care. We always, and Rachel did say a little bit of this, we care for the person in a different way. We change our focus. We withdraw the interventions perhaps. We decide to take away the medication, the IV medications perhaps that maybe aren't helping the patient a lot at this point. And those things aren't done like all of a sudden either. Those things are taken back or discontinued in a manner that is with attention to how the patient's going to respond to that, and also the family around them too. So I'm going to talk a little bit about palliative care. It used to be that the terms palliative care and hospice at one point were synonymous. For some people, they sort of still are, and they overlap quite a bit. The term palliative is a general term. Palliative in medicine means that we're at the point where we're not expecting to cure something.
but we will palliate, meaning that we're going to treat the symptoms. We're gonna treat the person if they have pain, if they have shortness of breath, if they have nausea. We're always going to treat discomfort, but we know that we're not gonna cure the disease. There's many conditions that at the outset, we know that in the end, those things aren't going to be cured. They're going to be something that the person struggles with as they move through their life. Rachel talked about this a little bit in terms of what will happen down the road. And I agree with her that I think that in medicine in general, you get told that you have congestive heart failure or that you had a stroke, or that you have cancer even. I think in a lot of instances, because physicians, medical personnel are very much concerned with treating the here and now, currently what is happening, that they don't fully explain what will happen over time, how things will change. Something like congestive heart failure isn't something that we expect to cure. We expect that you can have ups and downs with it, you can have exacerbations of your symptoms, and you can have decrease of your symptoms with appropriate medical treatment, but we don't necessarily expect to cure it. With something like a stroke, sometimes those patients have sequelae, meaning that they have maybe weakness, maybe they have nothing because of it, but that doesn't mean that and then we treat them appropriately as far as what we can do to prevent it, but that doesn't always mean that you will, never experience that again. So I would encourage you to remember that when medical issues come up, there are certain things that become chronic over time, and we don't necessarily expect that to improve over time, just like, because we're all aging, and because those diseases tend to persist and cause different things down the road. So the term palliative care, speaking of acceptance, I can't see like I used to either. So again, palliative care is a general term that describes palliation of symptoms, the fact that we're not curing, but we're treating symptoms. In the 1980s, two different institutions, one being the Cleveland Clinic Foundation, which this is something that I actually just found out last night. The Cleveland Clinic Foundation and the University of Wisconsin-Madison developed palliative units in their hospitals, and that was the first time that hospice and palliative became somewhat separate, in that they were defined as something that could be, I don't want to say different disciplines, but they could serve a different purpose for our population of patients. So in the modern world, palliative care, when you hear about being referred to palliative care, palliative services are generally more consultative. Consultative means you have a consultation with that practitioner. And that is what the main thing that I do when I work at the hospital. What I do is I get consulted on patients who need to talk about where we're at and where we're gonna go from here. In that conversation, it is a conversation about, medically what's going on, what are your choices from here. Choices from here include choices about the disease and its treatment. That conversation often includes things like placement, discussions about nursing facility versus care at home versus going home with home care, and that's where it becomes a little bit more complex. And so it's the discussion again about planning of care, and the planning of care always goes along with wishes of the patient. And then if the patient can't decide, it isn't in the condition where they can make those decisions. Of course, it goes to the family or the healthcare power of attorney, which he's gonna talk a little bit more about. Dr. Schweitzer already alluded to the fact that you can name your healthcare power of attorney. If you do not name a healthcare power of attorney, there is a legal progression of who makes your decisions from there, and it's your legal next of kin. So I talk to patients and families again about where they're at, where they're going from here, how they're treating their disease, and how they want to move forward with that, and then also, the situation in which they live and who's caring for them. Involved in that decision also is a discussion of what Rachel talked about, and that's, I often talk about resuscitation orders. And I say I talk about all these things, but the conversation, especially my initial conversation with a patient and family, is always guided by them, because there are plenty of times that I walk into a room and I start talking, and then they say, "Who are you?" And as soon as I try to avoid the word palliative to start with, I say, "I'm Stephanie, I'm one of the nurse practitioners here, and your physician has asked that I speak with you." And usually when I'm asked to speak to somebody, it's because you're facing something pretty significant in terms of your health. And so I preface it with that. Sometimes when they hear the word palliative, the lights turn off, and I can tell right away. So when that happens, I usually move forward in a way that's, conscientious of how that person is reacting, because obviously when I talk with a patient, especially about things of this nature, I want them to be able to participate in the conversation in a meaningful way. So I think it's important that we as professionals, again, meet people where they are and help them get through this in a way that is helpful for them. We never want to lie about what's going on, but we definitely want to help you through whatever it is in a way that truly helps you. So I usually end up talking about disease and where it's going, what kind of setting are we talking about, and then the matter of do not resuscitate, I often talk with patients about. So, there was something I was going to say, and I just lost it. So, it's the next thing on this list. Like I said, so palliative care is generally a consultative service. Unfortunately, in most situations, palliative care services are not an entire team of people. It is, but it isn't, because of, and it goes back to how it's covered by insurance, unfortunately. Medicare covers a comprehensive service that is palliative, that's called hospice. Medicare says that hospice has to be a team of this person, this person, this person, this person. Medicare reimburses that hospice in a way that allows them to employ all those people. Unfortunately, they haven't gotten to a point where they cover palliative in that manner, which is why palliative services are often a provider consulting. So it's often a nurse practitioner, sometimes a physician, who has these type of conversations. They can involve other people. Sometimes a social worker is available. Generally, if there are other services involved, like nursing services or aid services, home services, that's usually the service of home care. And so those services can happen together. Some people follow up with their palliative consultants. Some palliative consultants go into patients' homes. I would love to do that, but I haven't been allowed to do that yet, because of because of our current model. So there are palliative services. You will find that depending on the institution that does it, it's different. At Cleveland Clinic Mercy, I do consultations in an office at the hospital. There are some palliative nurse practitioners who come to your home and talk to you there. It just depends on how that organization has decided to do it. And again, they have to be conscious of the fact that they have to pay people for doing their jobs, and so it depends on insurance reimbursement. I should keep these glasses on so that I can see. Oh, the other thing is that it also does not include medications and equipment. Those things are probably covered by insurance and Medicare, but they are separate from that service of palliative care. So they can be ordered by somebody, but it's not sort of included in that in that capsule. So again, it's intended to be multidisciplinary. So often when I'm talking about, when I do my consultations, I am often reading the oncologist's note, the surgeon's note, the whoever else is involved, all the disciplines, because often once I'm consulted, there are many consultants seeing the patient. I always try to put together all of that and talk to the patient in a way that includes all those things. And then there are many times that I'm going back to Epic and doing a little chat and including all those people. I often talk to the social workers who are talking to the patient, so I often speak with many of the disciplines involved in the patient's care. So in the end, palliative care and palliative services the goal is to relieve suffering. Suffering is sometimes physical, sometimes it's emotional, sometimes I sit with patients and talk to them a while. Sometimes I'm helping them by relieving their shortness of breath. I've dealt with patients with shortness of breath who are afraid of the medication called morphine. And then I tell them, what if I ordered, just a little dose, a very small dose? You just get 1 milligram IV and see how it makes you feel. And so sometimes it's relieving suffering in that way, and I always, again, include those patients and family in those decisions to move forward with medications like that. And sometimes it's just a matter of, there's a lady that I've been seeing this week, and she is just, her suffering I can see is mostly emotional. It's mostly like, why is this happening to me? And I can't stand these symptoms, and I don't want treatment, but I also don't want to be uncomfortable. And so the other day, I was talking to her about, she commented on, my last name is Spicer, and she called me a Spice Girl or something like that. And then so it happened that I said, so it's funny that you say that. I said, my daughters and I are involved in an organization called the North Canton Playhouse. And she said, I used to do things at the North Canton Playhouse. And I said, oh, and then so we started talking about that. And then I said, well, why did we start talking about this? And I'm like, oh yeah, the Spice Girls. I said, because me and my daughters participate in that, the director there calls me and my daughters the Spice Girls. So that got us kind of on her talking about something that she was interested in, part of her life. And I asked her, do you remember what you were involved in? And so we had that conversation. So the next day she was actually feeling a little bit better, but then she had a couple of bad days. And so yesterday I decided to print off the North Canton Playhouse's list of the shows that they're doing. And so I printed that off the internet quick for her and brought it to her room. And I said, you know what, these are and actually my daughter's helping direct one of the musicals that they're doing. So I said, this is what's going on there. And I said, and we had already talked about the fact that her physicians feel like she can do okay for a while. And I said, if you're feeling good enough, maybe you would be able to get to one of these shows. Wouldn't that be fun? And so it kind of improved her mood. So I do I try to, again, like Rachel said, pick up on the things that are important to them in their lives and just talk to them about those things. Sometimes I can tell that the medical stuff just gets too much and we need to stop talking about that. And we talk about the things that are going on in their lives. I also, my second position is I do face-to-face visits for Mercy's Hospice. And so I see patients in nursing facilities. One of the things that I do when I go into a nursing facility room is you can see all their pictures in their room and stuff like that, and I like to comment on those things and ask them about their family. You know, that really helps, I think, in that whole situation of really thinking of helping people as a whole person and everything that's involved in their life. So, all right, I need to move on. So So palliative, again, palliative is a more consultative. It's a different model depending on what agency is doing it. On the other hand, hospice is regulated by Medicare as a covered service. And so Medicare says it has to consist of these disciplines, which all hospices do. By the way, if you have Medicare, you have the choice of any hospice in the world that you want to use, because every hospice is Medicare certified, otherwise they would fail to exist anymore. Because it doesn't matter what your managed plan is, it reverts to traditional Medicare and you get to choose whatever hospice you want. So hospice is a service that anyone is eligible for if your prognosis is considered to be 6 months or less. That doesn't mean that once you get to 6 months, you get discharged from it though. Two physicians have to say that your prognosis is 6 months or less. The other thing that's pretty important, that I think is pretty important, is that you really have to be dedicated to comfort care. So at the point where you have a 6-month prognosis and you've come to the point of acceptance, and again, palliative services and hospice, those care professionals are there to help you through whatever stage of grief that you're in. So once you have a 6-month prognosis and you're dedicated to comfort only, I tell people that hospice is the best service when you're at that point, because it is what's going to help you live the best you can for those 6 months or a year or however long it is, and have the best quality of life. So they also specialize in symptom management and, again, quality of life. The goal when you get on hospice isn't just to medicate you until it's all over. I know some people have that impression. In cases where I've seen people have the impression that you go on hospice, you get morphine and you die, most of those patients, it's because they got on hospice really, really late, and they didn't have, and they had very little choices left except for managing those very, very end-of-life symptoms. So those medications, morphine and the medications that go along with it, are to be used for symptom management. Symptom management is if a patient is in pain, short of breath. If the patient is at the point where their mental status is no longer there, we judge that by how fast they're breathing, how fast their heart is going, and if they're restless. So those medications should be saved for treating those type of symptoms. So the only qualification for hospice is that you have a 6-month prognosis. You can actually retain a full co status when you're on hospice. I don't recommend it just because it gets very complex for the caregivers and for you and your family. I always recommend being dedicated to comfort only if you enroll in hospice. So when a patient or family agrees to hospice, again, you must agree and you sign an enrollment paper The enrollment paper says, yes, I have agreed to come for care only for my terminal illness, and lets your insurance, or for most people, it's Medicare. It lets them know that you have made this choice, and then they start reimbursing for hospice for everything. That is why then hospice uses that money to pay all their staff and to pay for many of your medications and all the equipment that you need. That's one of the benefits of hospice, is that that service includes all those things so that you don't have to be approved for equipment and medication separately. The hospice can decide as a team what's most appropriate for you, the patient, and get those things for you. So, there are different levels in hospice. I'm not gonna go into them. One of the things that I am gonna mention is respite care. Respite care is something that's covered under the hospice benefit. Everybody has the right to have the patient stay in a respite stay, which usually means going to a nursing facility for up to 5 days to give caregivers the rest that they need. So there's other levels of care that are based on the patient's needs and symptoms at the times, but that respite care is a little bit different in that it's to provide relief to the caregiver, or to even let them go on out of town for a week or whatever the case may be. The disciplines, so Medicare says that hospice, and every hospice consists of this. They have a physician that is the hospice medical director. Your primary care physician also can still be involved in your care. You get to choose who is your primary physician for that hospice episode. So again, there's a hospice medical director. There will be your primary provider, which some people choose the medical director. Nurse practitioners are involved as doing the regulatory visits. Like I said, there's something called a face-to-face visit that a nurse practitioner or a physician can do. In many cases, it's a nurse practitioner. A nurse practitioner can also be your primary provider when you're on hospice. So, nurses tend to visit 2 to 3 times per week on hospice. And again, so the hospice works with you to make a plan of care for you and for the patient and family that works for them. And so they visit during the week. A social worker is always involved. Social work is something that we haven't specifically touched on. We've kind of touched on the nursing part of it and the physician part of it. So social workers have a role. They help a lot with mental health, emotional health, helping families figure out what's best for them, helping out with things. So they often are the ones that arrange a respite stay. They are, and I think we need to include social workers more often, because I think they're better communicators sometimes than physicians or nurse practitioners are. And again, they're a vital part of the hospice team in helping the families figure out throughout that hospice episode where they're at and where they're going from here and what other things that they might need as far as resources to help their mental health as they go through this. So sure, spiritual care is always a part of the hospice team. Also, they come from many different spiritual backgrounds, and they help the patient in regards to their own spiritual background. So they do an assessment just like every other discipline, and the spiritual care person will make a care plan with that patient and family just to decide what it is that they need to provide for them. There are volunteers. Volunteers can provide many different services. It depends on the volunteers you have. Some of them, we have some hospices that have pet therapy volunteers. There are some that provide music services. There are some that just sit with patients. So that kind of varies from hospice to hospice as to who their volunteers are and what their gifts are. And then there's bereavement. So bereavement is something that is provided for families for a year after hospice finishes. So hospice obviously finishes at the time of patient's death. They follow that family or individuals from that family for a year following that. That often includes, many hospices have a memorial service at some point every year, and then that is part of those bereavement services. So sometimes dietitian and therapies are involved, but not that often, because again, once you have agreed to that service, you are usually wanting comfort only, and normally, once in a while, therapy or nutrition is part of that, but often those things can be accomplished with the staff that they have there. And I forgot to mention nurses' aides. Nurses' aides in hospice are often everybody's favorite because they see them the most often and they help them the most with physical care. I have many times seen confused patients at a nursing home, and they don't remember anybody else's name, but they remember Tina, because Tina is my aide, and she brings me chicken. And she, so like they just, the aides, because they're one-on-one doing personal care with them, they're often everybody's favorite. So they are a vital part of that team also. I already mentioned insurance coverage a little bit, and I'm probably way over, so. Again, hospice and home care are covered as a service under insurances. You have to qualify, and then it's covered in episodes. Then, so palliative is covered differently. It's often covered as a provider visit, and so that's why it's different and it's less comprehensive, but it is designed to provide a consultation to help you figure out where you're at and where you're going. So that is about all I have to say. And I was trying not to put you all to sleep, but it's getting up to the 2 hours now. So does anybody have any questions?
I've heard that even though you go on hospice, you can elect or maybe something improves in your office. Because people will fear hospice.
Yes.
And sometimes they'll freak out.
Correct. So right, that's an important thing that I didn't mention. So I mentioned that when you choose hospice, you enroll in hospice. So you sign a piece of paper saying, yes, I've chosen comfort care for my terminal illness. That is not something that is set in stone. Anybody who enrolls in hospice has the power to revoke hospice at any time. Revoke means you choose to go off. You do have to continue to qualify. That's another thing that that's one thing we've run into with COVID patients, that they are sure are going to continue to decline and pass away. And then they get better. And their other chronic illnesses maybe don't really qualify them for a 6-month prognosis. So number one, anybody has the power to revoke once they go on. It's not set in stone. Number two, your hospice may decide that you're no longer appropriate because something has changed. That means that we're not so sure that that 6-month prognosis that is required is still there. So, yeah, so if you enroll, or if your family member enrolls in hospice, you can change your mind at any point. Go ahead.
If you're in hospice, is the patient allowed to have a feeding tube? Are there any other rules that?
So generally, once you enroll in hospice, and again, this is why I mentioned that you have agreed to comfort only when you enroll in hospice. Normally, once you've enrolled in hospice, everything is geared towards comfort. So, normally, once they're on hospice, a feeding tube would not be inserted after that, or, they wouldn't have an operation once they're on hospice. If a patient has a feeding tube and is getting fed and enrolls in hospice, they can continue feedings through that tube. We would normally, one gentleman was talking about the fact that, so at some point, patients sometimes get to the point where the feedings are actually detrimental because their body can no longer manage the fluid, their heart isn't pumping their fluid through, right? So the hospice would advise them on maybe when it should be turned down or maybe even turned off because it's becoming detrimental. But if they have a feeding tube going into hospice, those patients normally do keep those and continue the tube feedings. It wouldn't normally be a procedure they would do after they're on hospice. If you came to that decision though, you can revoke hospice, get a feeding tube, go back on hospice. However, that doesn't happen very often because most patients that have decided to enroll in hospice, that discussion has already happened and they've decided against it. So there are some procedures like patients that have to have their lung drained of fluid, their belly drained of fluid. Sometimes those type of procedures do happen while a patient is on hospice. If they need it for symptom management to control their shortness of breath or pain.
So you probably won't have IV antibiotics.
Correct. In most cases, a hospice will not do IV antibiotics or IV fluids. They would normally manage those things in a different way. Oral antibiotics. I know there's at least one hospice out there that doesn't actually do any oral antibiotics. It's up to that hospice, and again, it's always in consultation with the patient, but most of the time, any medications that are still benefiting the patient should continue. And treat for a person who is doing relatively well and is early in that 6-month prognosis, if they get a UTI or an upper respiratory infection, there's no reason to not treat it if they can still take those oral antibiotics. So. Anybody else?
I don't know if this is a time for this, but I know two instances where a person was dying. Everyone gets tunnel vision on the person dying, and a caregiver almost dies because everything's focused on the person. There's a lot of pressure on a caregiver.
Mm-hmm.
We had a lady, she had COPD, no one knew it. She was giving attention to her Alzheimer's husband. And is there anything being done to watch caregivers to see that they...
Right, so one of those different disciplines, and especially, what you're talking about, would be probably the role of, well, all of them, nursing and social work, and the aides, because they're in the homes quite a bit, they see quite a bit of the caregivers. When a patient is in hospice, we are caring for that patient and their caregivers. And so attention should be paid to that. And that is, and that is why then, the service of respite, to give a break to those caregivers. And so, yeah, social work has a big part in then facilitating what are their options if the caregiver is having lots of trouble. So, or has their own issues. I've talked long enough.
And now we're gonna do some jumping jacks and stretches, just kidding.
Seventh inning stretch.
That's right, 7th inning stretch. We'll do some jumping jacks and, but thanks for giving me your time to talk about Advanced Directives 2, and thanks Kay Watson for inviting me and Barb and the Church of Christ in Dover for opening up your church building to us. And I want to say thank you to the sound booth folks as well. Just by way of very brief bio, I'm Travis Gingrich. I'm manager of pastoral care at Cleveland Clinic Mercy Hospital, and I got my BA in Bible and Theology at the Moody Bible Institute, and my master's through Trinity Evangelical Divinity School before I became a chaplain. And I got my feet wet in ministry doing, I thought I was going to do teaching and preaching, and I got into that a little bit and learned very quickly that that certainly has its place. But the old saying, people don't really care what you know until they really know that you care, and got involved in chaplaincy where I get to care for people in that way, which brings us to advanced directives and taking care of people in terms of thinking through matters that do need to be taken care of. In pastoral care, we've handled lots and lots of these as well. But I also want to say I'm really, really grateful, Dr. Schweitzer, that you had mentioned and asked, why are you here? And people mentioned either here for myself or here for a loved one, and that's really important. Asking why we're here and what we hope to get out of this as well. So I hope this is helpful for you. If you didn't already get some handouts to take home, there's some handouts on the back table. So on your way out, feel free to help yourself to any of that as well. But first, no, don't want to block the PowerPoint either, so I'll stand back a little bit. I'd like for you to imagine a situation in your own life experience where you had to discuss something that was maybe uncomfortable, but you just needed to go there to avoid a greater discomfort or problem later on. Think about a situation like that. Can you recall such a conversation? And here's a story about that kind of lack of a conversation that didn't happen and the problems that it caused. I read a situation years ago, a true story, about an elderly lady who had put her entire life savings in cash in a mattress. She stuffed it in the mattress. And according to the story, a mattress that has seen, by the way, I'll say parenthetically, that she kept for a very, very, very long time. Well beyond the recommended, 9 years or 5 years or whatever they recommend for mattresses. Now her savings was very, very important to her, obviously, but she never told anybody about it. She kept it to herself. And what happened was, in the end, there was the equivalent of about $1 million US in that mattress. Yeah, I don't know how she kept it in that mattress, but she did. And she decided to celebrate. Why not? Once she reached that amount of about $1 million USD, and she went on vacation. Now, her daughter, seeing that she was treating herself for the first time in a very, very long time, decided to do something nice for her. Yes. Yes, what you're thinking is right. She decided to buy her, can anybody guess? A new mattress. Yes, a new mattress, that's right. Now, the elderly lady came back from her vacation, refreshed and restored, and suddenly, to her horror, realized, where's my mattress? And her daughter, seeing that she was alarmed, said, you know what? It's okay, Mom. Don't worry. Don't worry. I took care of that. The trash people already came by and picked it up for her. Now, we can't really blame the daughter. She meant well, and she's trying to help. She's trying to treat her mom, but we can see how a few carefully thought out questions could have maybe prevented this. Of course, she didn't want to spoil the surprise, but there it is. And by the way, they did look, and they had search teams looking in the trash and the what do you call it, the place for the landfill, and they never found it, reportedly. True story. Now, think about a story in your own life where you needed to have a conversation about something, but you just didn't want to. All kinds of reasons why. Maybe it's uncomfortable. I don't want to broach the subject. I might cause some discomfort. I might even make them mad at me if I talk about this, or I'm just embarrassed to. All kinds of reasons why, but think about a time in your own life where maybe you could have even avoided some pain or embarrassment or uncomfortable feelings, if only we could have had that candid conversation. And when it comes to healthcare decision making, have you ever talked with your loved ones about what you would want in a medical situation if you can't speak for yourself. And in my experience in talking with patients and families about this, those conversations don't happen nearly enough. And all the time I talk to people who they took the information home, they wanted to think about it, and they got home, and understandably so, we're busy in our lives. And they put it somewhere on their desk or at home, and then life got back to normal, so to speak, and they forgot about it until the next crisis happens. So I understand, I don't want anybody to feel badly about it, but just it's one of those things that is so important to happen, but just doesn't happen enough, and it's an important conversation to have. So what are advanced directives, and why do you need them? Well, first of all, what they are by saying what they're not, because this is something that I encounter all the time. It's not about property or finances. When people hear the word power of attorney, for example, they immediately think about, who am I giving permission to for my stuff, my property, my money? That's a very important document too, but that's a different document. That's a general power of attorney, whereas this would be a healthcare power of attorney. Also, people hear the word living will and they confuse it with a last will and testament. That's different. Or a will in regards to, again, your assets, your stuff. Very important. That also should be done, but that's a different document. It's not about your house or your money or your assets or your property. It's also not just about end of life. You see the hourglass at the bottom. It can certainly deal with that, and it does, and that's why we're talking about it today. But it's not only about that, and that's why I encourage everybody to consider having one, even if you're not end of life, because it's just an important thing to have as well. Ideally, these are done before crisis. Rachel mentioned that, I think Dr. Schweitzer mentioned that. Sometimes people wait until crises come to talk about these things, and then emotions are high and it's difficult. I personally recommend having those conversations when things seem normal, when life is not in crisis mode. What they are, what's the purpose of the document? Now, if you can speak for yourself, you're in the driver's seat. You tell your medical team, your family, your loved ones what you want. But if you cannot speak for yourself, that's when these documents come in handy. That's what they're for. If you are not able to speak for yourself, it allows you to direct ahead of time, hence the word advance, directives, what you would want if you can't speak for yourself, because we want to honor your wishes. They are optional, and again, they only go into effect if you cannot speak for yourself. You're not giving away your autonomy or your freedom to choose. You're actually projecting it into the future for when you can't speak for yourself. You are helping us, your medical team, your loved ones, to know what's important to you. And that can take place at any time. When do these take place, and what are they about, and when will they be honored? Well, they'll be honored insofar as the directive is, of course, ethical or legal. That kind of goes without saying, but if you're asking for your medical team to do something that's, well, illegal, we can't do that. So no euthanasia or things like that. So there are certain things that, of course, you can't, you're not gonna do that we won't honor. But that being said, we want to honor your wishes. We want to honor what you want. Some folks in the community might want this. This is a resource about advanced care guidance from a Catholic perspective. They have these great pamphlets that are out there. If you want information, you can find them. That information's on your handout as well. Those are nice to have. But also, we just want to make sure that your wishes are honored. Like this guy. Dogbert is somebody that you don't want as your healthcare power of attorney. You're giving that person a lot of authority. Family are always involved, of course, in these kinds of discussions, but they don't call the shots. It's about what you want. It's about your wishes. I've encountered families where, the patient's sitting in the bed, we're talking about advanced directives, and the loved one or family member is sitting there on the chair on the side, and I'm talking to the family about I'm talking to the patient about what they want. And sometimes, the family member or the loved one keeps cutting off the patient or speaking up or speaking over the patient. I think sometimes that's just nervous energy. But sometimes it can kind of come across as, oh, I'm going to tell you what I want. And I'm always clear to pivot back to the patient and say, that's good to hear your feedback. And we're asking, what do you want, the patient? What do you want? Because at the end of the day, it's about your wishes, your preferences. And that is just so important. You know, if somebody is speaking over or cutting off, I always want to just pivot back and say, this is about you right now, and what do you want? So that being said, it's really important to know who your healthcare power of attorney is, and to have this document filled out. At the end, you'll have it signed by 2 witnesses or a notary. I get this question a lot. Do I need to have a notary? You can. Or 2 witnesses who are not related to you in any way, and not mentioned anywhere in the document. There can't be any conflict of interest, so it can't be your physician, it can't be anybody that's named, but it can be a neighbor, a friend, and in some cases maybe even your nurse. The facility lets them do that as well. It's just basically anybody who's disinterested, and it wouldn't cause a conflict of interest. Or you could have it notarized. You could take it to a bank, and most banks will do that for you for free. Or other notary publics can take care of that for you. But at the end of the day, it's about protecting your wishes and your rights and what you want, and there can't be any coercion or undue influence. That's what the witness is saying here, that I attest that the principal signed or acknowledged this in my presence, that the principal, that's the person filling it out, appears to be of sound mind and not under or subject to duress or fraud or undue influence. So no one's twisting your arm, like this guy. I'm gonna make sure that's not happening. Now, the healthcare power of attorney, you're giving this person a lot of authority, so make sure that you choose that person carefully. I would also say this, please don't just fill out the form and put it on the shelf. It's good to have the document filled out. Having your paperwork done is important, but this is so much more than that. This has to be, I think, it should be, needs to be, a conversation, and not just a conversation. As Rachel and Dr. Schweitzer and Stephanie mentioned, ongoing conversations about what you want. Because people forget things, and sometimes we need clarification, and life changes. Your life situation will change, your relationship to people around you will change, your understanding about things will change. So yes, select the healthcare power of attorney, select that person carefully, and have ongoing conversations with that person. That is just so important. And please understand too and know that this person that you're choosing will have the authority, if you can't speak for yourself, to make decisions for you in a very broad application. Pretty much any decision that you would make for yourself, whether or not to have surgery, what facility to receive treatment at, whether or not to receive a certain medication, all kinds of things. And they're making those decisions on your behalf and in your best interest, and according to what they believe you would want. But at the end of the day, they're making those decisions, and it's possible for them to choose something other than what you want. I was in a situation recently in the ICU with a family who was making decisions for a loved one, and in the end, they did decide in the patient's wishes. And this patient was terminally ill, and but they remarked, they said, we want to have a little bit more time for other family to come in and say their last goodbyes. Understandable. But they also said, sort of on the side, they said, and she wouldn't have wanted to live like this on machines. And if she only knew that she was still on the machine at this point, she'd be upset at us and she'd smack us around. And now, I understand in this case they wanted other families to say their last goodbye, and then they were going to do that. And they did. These situations can be complicated, and you can't possibly predict every situation, of course. But you can make your wishes known, and it is important to make your wishes known so that people have a sense of what you want. Because it is possible for people to get their own will involved, to get their own volition, their own wishes, their own emotions tangled up in it. That can happen. We are, after all, only human. And in making a decision for someone else, it is challenging to set aside what I am feeling and to say, what does my loved one want? What would they have wanted? It's hard to do. So choose carefully, have those conversations, and make sure that you keep those conversations ongoing. What if it's just agent. Agent means your healthcare power of attorney. I like to say if people write their name twice, they're a double agent. Sorry. Now, what if you don't have the healthcare power of attorney? As was mentioned, there's a hierarchy basically that says your next of kin. Well, who's that? And this is why this is really important too, by the way. If you don't have a healthcare power of attorney, your next of kin would be your guardian if you have one. If you don't, then your spouse if you have one. I'll pause right there. Some people are perfectly fine with their spouse being their healthcare power of attorney. Some people aren't. Everybody's different. I don't pass judgment. It's just everybody's different. I've actually encountered, not many, but some, who didn't want their spouse to be their healthcare power of attorney. That's fine. That's what they want. But much more commonly, what I find is, I do encounter this quite a bit. People who aren't married, but they have a significant other that they've been with for, 10 years. And they want that person to be their healthcare power of attorney. And they just assume sometimes that if they lose decision-making capacity, that person will be their decision maker because, well, they know me and they've been with me for so long. But the fact is, if you're not married to that person, they're not your legal next of kin. And so who would be? Well, gosh, this is where it really gets sticky because let's say that someone is separated, but not divorced. I've seen this, and they have a significant other, and they want the significant other to be the decision maker. Oh, but they're still technically married to someone else. Well, if you don't have a power of attorney written, it's your next of kin who's the decision maker. That could get sticky, or even if you don't have a separation involved, and you really want your significant other to be your decision maker, but you don't have a power of attorney, guess what? It goes next to your kids. You might be fine with that. You might not be fine with that. So it's really important. Here's another thing. Dr. Schweitzer mentioned too, sometimes what if family don't see eye to eye? Sometimes they do and sometimes they don't. And that's where the next step there, majority of adult children, what if you have an even number? What if some live out of state, they can't be easily reached? That's fine, they'll still call. But what if they don't agree? What if they fight about it? What if they squabble? And having that identified person can be so helpful. There still might be conflict. You could have a healthcare power of attorney chosen from among your children, and everyone has conflict with the decision maker. Understandable. This doesn't eliminate conflict, but it can help, and it's a good thing to have. This also can be a starting point for a conversation with the siblings, so that if something happens, at least they have a starting point. There's a lot of confusion. Some people say, oh, it's the eldest, or I'm the eldest child, so I'm the eldest sibling. I get to, at least in Ohio, it doesn't matter who's the eldest. It matters that the majority of adult children, not necessarily who's older. So that's a common misunderstanding. Next would be parents. If they're still alive and of decision-making capacity. Then majority of adult siblings, there we go with majority again, and then the closest living relative. And if there is no power of attorney chosen and these people can't be identified, until a POA is established, really anyone claiming to speak on your best interest can pop in and be that decision maker until they can find that next of kin. You just want to avoid situations where there's a question mark about who to contact. Let's say they don't know who the children are. Sometimes it might not be apparent to the medical team how to reach the next of kin. It's just a good idea to have it in place. So I highly suggest that everybody have one. Now, who do you put? Generally, you can put one healthcare power of attorney. You can put more than one if you want and give them co-equal authority, but they both need to be available. They both need to be available at the same time and see eye to eye. It can be complicated. So what a lot of people do is they have one power of attorney chosen, and then you can have an alternate power of attorney and a secondary alternative, and it would go in that order. So they would call your agent, your power of attorney. If that person can't be reached or something happens to that person, they go to the next person in your document, and then the next person. So you can have like a pecking order, call this person. So for me, my first is my wife, and then my dad, and then my sister. That's how I have it set up. So they would go in that order. And you could do that however you want. And if you have those kind of conversations and have this established, it could avoid misunderstandings like this. Again, I wouldn't choose him. I just wouldn't choose him. But talking about it's important. Again, you can't cover every possible future scenario, but you can make it known what's important to you. This is hugely important. I had a conversation with my dad about this years ago because my mom is his healthcare power of attorney, and then I'm his alternate. So if something were to happen to both of them, I would be the decision maker in line. And so I thought it was really important, especially if I'm doing public presentations about it, right? I should lead by example and talk to them. So I had this conversation with my dad. What would you like me to do? Help me understand your wishes. And I'm really glad we had that conversation, because his words to me was, he's a man of few words sometimes. He studied drama, so he can go on, but sometimes he's very just brief. And he said, no heroic measures. And I thought, okay, no heroic measures. Now, in my mind, that means one thing. In somebody else's mind, it might mean something else. So I might feel some hesitation to ask for clarification, because I might say, I'm embarrassed. I don't want to admit that I don't know what you mean. I don't want to look stupid. At the same time, I don't want to misrepresent your wishes, which is actually more important, right? What's more important, my pride or my dad, his wishes, right? So I said, what do you mean? What do you mean by that? What do you mean? If you collapse, do you want me to do CPR? Do you want the squad to do CPR? The answer is yes, yes, yes. By no heroic measures, he didn't mean don't do CPR. What he means is, yes, if I collapse, do CPR, do chest compressions, do what you need to do. But if I'm permanently unconscious, if there's no reasonable hope of recovery, if this isn't going to help me anymore, if I'm not going to recover from this most likely, then don't keep me alive for the sake of keeping me alive. Focus on comfort care and don't prolong the dying process, is essentially what he said. And that was very helpful for me. So when we talk about code status, he'd be a full code, go ahead and do CPR. But if he's on machines and they've done whatever they can curatively, let's not keep going that way. That's so important. What does it mean? I've seen both situations where people have never talked about it and where people have talked about it. And I can tell you that generally speaking, in principle, there's heightened anxiety, more so when it's never been talked about. When it has been talked about, it's usually still a hard decision. These decisions are seldom easy, but they're easier. When the family can say, you know what, this is really hard, but I know we had this conversation and we talked about this, and I know that I'm carrying out her wishes. That is so helpful, and that really, really helps. Now, you can give as much or little authority to your power of attorney as you want. You can cross certain things out in the document. Usually people don't. But again, I would say the most important thing is have that conversation with your healthcare power of attorney. There is a special section that allows you, if you want, to give authority regarding being in a permanently unconscious state. Do you want to give your healthcare power of attorney authority to make decisions if you're permanently unconscious in terms of withdrawing that care, curative aggressive treatment? Yes, you can specify that in the document if you want. But just know that this document is very general in its application. The long story short is you're giving authority to the person of your choice to make decisions in a broad sense about what you want, and they would decide on your behalf. That's the healthcare power of attorney. That living will declaration is next. This is different. This is if you are unable to speak for yourself and you are permanently unconscious or actively dying and there is no reasonable hope of recovery. And a doctor has examined you and another physician well and has determined, as the document says, to a reasonable degree of medical certainty that this isn't going to benefit you anymore. And can allow you then to direct your physician ahead of time in that situation to take you off of life-sustaining treatment, to direct that your dying not be artificially prolonged, and to keep you comfortable. That's the living will document. It explains it more in detail, but I would say know and understand that this document is not saying I'm going to kill my loved one. I've had people talk to me who were morally distressed because they felt that in invoking the living will, they felt like they were killing their loved one, as it were, pulling the plug. And I would just like to say, by way of reassuring you, if you're in this situation, you are not killing your loved one. The disease is doing that. You are not hurting your loved one. The disease is doing that. This document is simply allowing you to honor their wishes, to not artificially prolong the dying process if it's not going to help them. Its intention is in love to honor their wishes. So if people feel morally conflicted about that, I understand that. A lot of people may feel that way, and what a lot of people have found is that's not what it's about. That's not what it's about. The disease is doing that. Again, another thing about this document is that you're giving authority to your physician, not to your loved one here. So what if you have both a healthcare power of attorney and a living will? Well, the healthcare power of attorney gives authority to your loved one that you're choosing. The living will gives authority to your physician in an end-of-life situation. So, if you have both, what happens? Of course, the medical team will reach out to your family and want to know what they think and get their feedback and involve them, of course, but the living will controls over the healthcare power of attorney if you have both filled out. That's really important to know. So let's say that you have both documents filled out, and a lot of people do, I do. And if the situation becomes permanent, now you're permanently unconscious or you're dying, and there's no reasonable hope of recovery. And so the living will comes into play. Your power of attorney will need to know and understand and accept that you have a living will declaration, and that living will declaration controls and is the document that says what you want. Now, if you're thinking of filling this out for yourself, it's a good question to ask. Do I want that? Some people choose to fill out just the power of attorney and not the living will. Some people choose to fill out both. It's your choice. It's up to you. Just know that if you have them both, the living will document controls. That's really important to know. Another important thing is that the living will is not a DNR order. A living will document, even though it says DNR in the document, does not say that if you, say, collapse and your heart stops beating, it's not telling the squad to not do CPR. It's not a DNR order. It simply says that if this is the situation you're in, these are the steps that are taken, and a DNR order would be issued at that point. But that's not to say that if you fill out a living will, you're also filling out a DNR right now. That's not the case. So in the case of my father, in the case of me, we both have living will declarations, but we're both full code. If I collapse right now, please do CPR. Okay, so DNR is not this. Those are different documents. Okay, I'll move on here. VA, just by way of a small mention, if you're a veteran, you can use these too. Do we have any veterans today? Any veterans? Okay, okay, excellent. Thank you for your service. Excellent, good. Those are very similar to the state forms. They're a little more specific. They look a little different, but those are available. You can go to va.gov, click on their website, you can look that up. That is available. Either way would be fine if you're a veteran. Ethical considerations, religious considerations. We mentioned, the bloodless program, blood conservation program as well, that a lot of people really favor for various reasons, Jehovah's Witness community especially so, because of their beliefs. But religious and cultural considerations really come into play with a lot of this as well. The Jehovah's Witness faith community, for example, usually use their own advance directives that has language specific to blood products. So if you encounter a loved one, or maybe if anyone here today or someone you know is Jehovah's Witness community, just know they do have their own advance directives with their own language and preferences there, and their elders, their church leaders basically, can help them with that as well. Organ donation, I'll just say that's a personal decision. It has broad support among a lot of faith traditions, and there's a website that talks a lot about that. But it's a personal choice. Sometimes people ask me if I should be, and that's a personal question you can mull over and think about. Consider your own values, though. Consider your own beliefs, your own religious convictions, even your theology, your beliefs. Sometimes a lot of this can come into play too, I'll say as a chaplain, when people have the thought of, well, but what about if God could do a miracle, and what about that, and those kinds of questions. I mean, it's something worth thinking about. I won't get into the weeds on that right here, but just know that your own beliefs and your own thoughts can really play a big impact in how you think this through. And if you're really wrestling with some of that, talk to chaplain, talk to your doctor, talk to a faith community leader, somebody who could hear you out, especially in relation to religious matters or faith matters. Chaplains are excellent people to speak to about that. But know that those are important things to think about, because at the end of the day, this is about what you want as well. Talk with your pastor or your religious advisor, or some people even want to talk to their lawyer or financial planner, all kinds of people who can help you think about all kinds of advanced care planning issues, and I encourage you to do that. So those are what advanced directives are, and I want to be cognizant of time, so I'll wrap this up pretty quickly, but just in case I haven't already convinced you why to get these done, I'll just give a few additional items as to why this is important to do. Sometimes people might say, I don't need to fill these out, right? Because God will take care of the details. Yes, that's true, yes. At the same time, God often works through communication tools like this, and it will make it easier on family if you do them. So, yes, trust God and fill out your advanced directives, right? So, definitely. That's right. What's that?
Are you a preacher or a politician?
I'm a preacher, but yes. I don't want to have this conversation. It makes me nervous. I understand that. In talking with my own sister about this, she said, these kind of conversations are awkward. I said, but they don't have to be. They don't really have to be. Sometimes people say, I don't want to talk about it. I'm not talking about it. It makes me uncomfortable. You know what? A lot of people don't like to talk about it, and yet they need to. Somebody put it this way, it's always too early to talk about this stuff, until it's too late to talk about this stuff. So talk about it, even if it makes you uncomfortable. When I was in junior high, I had an uncomfortable experience that could have gone better. We probably have a lot of those. But in my youthful pride, I avoided, I decided that I would do my laundry on my own, right? I wanted to be a grown-up, so I wanted to do some laundry. It's a good and noble task, but I didn't ask my mom to teach me because my pride got in the way, right? I didn't want to talk about it, so I didn't. Has anybody been there? You want to talk, you want to do something and you're embarrassed? I'd rather just do it. I'll just take care of it. So I washed the cottons along with the delicates in warm water. Oh, and even worse, I decided not just to wash my own clothes, but to be extra helpful, I decided to wash my mother's clothes as well, which included her pantyhose. And you can imagine what this did to the pantyhose, right? What do you think happened?
It came out just perfect.
Yeah, they came out just perfect. And they came out about this big. And, you could imagine my mom's response. I was forbidden from doing laundry ever again. And thankfully, my wife is grateful that I have since disobeyed that prohibition and have continued doing laundry. But I have also learned to always ask when in doubt. And that's just a good principle. Ask, talk about it. you know, this is a cotton polyester blend. I should put it in delicates on cold, right? So always ask. It's better to risk having an uncomfortable conversation or to breach an uncomfortable topic than to have an upset later on. Okay, what else? It's too confusing. I'm just looking through this document. It's all small print. It doesn't have to be though. It can be confusing, but you can seek advice or guidance. Again, if you want to go to an attorney who can walk you through that, that's fine. But it doesn't need to be complicated. It's pretty straightforward. We want to know what you want. Your medical team, loved ones want to know what you want. Another objection, and I've heard this, my family already knows what I want. They already know what I want. That's a dangerous thing to say. Now, we can assume that because it's a typical tendency with us to think we know what the other person's saying or to think they understand us or for us to understand them. And that's not always the case, as we know, right? Just like I know how to do laundry. Thought I knew. You might not know, and you might not be on the same page, and you might think you are. Do we have time for the video clip? Okay. Otherwise, you could end up like these two guys.
I'm sorry to hear that.
How is your brother-in-law in America?
Oh, he's doing very well.
Oh, he wrote you?
No, not lately.
How do you know?
If he was doing badly, he would write.
Fine. Teddy.
Yeah.
I suppose you know why I wanted to see you.
Oh, yes, I do, but there is no use talking about it.
Terry, I understand how you feel, but after all, you have a few more without her.
I see. Today you want one, tomorrow you may want two.
Two? What would I do with two?
The same as you do with one.
Terry, this is very important to me.
Why is it so important to you?
Frankly, because I'm lonely.
Lonely? Rebecca, what are you talking about? How can a little cow keep you company?
Little cow? Is that what you call her?
What else should I call her? That's what she is. Rebecca, what are you talking about?
Don't you know?
Of course I know. We are talking about my new milk cow, the one you want to buy.
Little cow? And your cow's so lonely. I'm talking about your daughter. Your daughter's Seidel.
My daughter, Seidel.
Of course, your daughter Seidel. I see her every Thursday at Butcher Shop. And she's met me.
Oh boy, married your milk cows, you know, what are we talking about? Just like my dad when he said, just when I was talking to my dad and he said, you know, no heroic measures. Well, what do you mean by that? Let's follow that up. Let's make sure we're clear. That's so important because we can talk right past each other and not even know what that means. So make sure you're on the same page. Have repeated conversations. Again, I want to underscore that because, you know, you might feel understood and heard, and maybe they really do hear you, but time passes by and things change, and things can get foggy. So make sure you have those conversations. Don't assume that you and your loved ones are on the same page. Another reason to do it, it affirms your dignity. You matter. You matter as a person. And so because you matter, your choices matter, your wishes matter, what you want matters. It affirms your dignity. So talk about it. Talk with your family and friends and loved ones about it. Talk with your significant other about it. Talk with your spouse about it. Talk with anybody you want to involve about it. And talk with your doctor about it. It's one thing to have those things in writing, but again, it's so important to have that face-to-face, eye-to-eye conversation with your medical team as well, so they can hear from you what you want. If it's just sort of buried in a chart somewhere, okay, that's good. You should fill out the paperwork, but again, those conversations are just crucial. So that's why you should do them. So doggone it, just get them done. Please consider, if you already have, review them. I got my directives done in like 2013, something like that. It's been like 10 years. I should review them. And I need to talk with people about it again. It's a good thing to do every once in a while. Encourage other people to do the same and put it on file. People have asked me, where should I put it on file? Again, personal choice. You could put it on file with your hospital, with your doctor's office. I would recommend that, but it's up to you. Just keep in mind, if you do revise your directive, it'll take the place of previous directives, right? A newly filled out directive will supersede any previous directive. That's important to know. So if you fill out a new one, you'll want to make sure you communicate that and give a copy of the new one to anybody you've already given it to. So if you put it on file with your doctor's office and your hospital and gave a copy to each of your loved ones that are involved, make sure you know who you gave it to so you can give the new copy to the same people so there's not confusion. It's important. If you want more information, these websites are on your handouts as well. If anybody didn't get a handout and they forgot later on and they said, where was that? You can email, contact Kay, she can reach me, we can get you that information. But some great websites that answer a lot of questions as well. There's also a great handout from the Ohio Bar Association. I'm not going to read that entire link, but that's on your handout. You could also just type into Google, Ohio State Living Wills and Healthcare Power of Attorney pamphlet, and it will bring that pamphlet up for you. Or you can just take home the handout as well. So those are all important. I know I've gone past the time, and I'm sorry about that. I know that I want to respect your time, so I apologize. You can be mad at me, and I will accept it. Any questions? Drinks are on the house. Yes.
Is it better to do this like online, or is it better to go to an attorney?
That's an excellent question. It really depends on your level of comfort. Just like anything else, right? Filing your taxes or going through a mortgage or whatever. I mean, all kinds of things where we can use tools, where we can do it in person with a professional. That's really up to you. Some people feel more comfortable sitting face to face with a professional and having them work through it. That's perfectly fine. A lot of people, though, do like to do it online and just fill out the documents themselves. Either way, it's up to you. You could look at the documents and work your way through it, and if you feel uncomfortable with it, and you feel yourself befuddled, or you just want more guidance, at that point then, sure, you could reach out to somebody else. If you want the documents, you can get them online at the Ohio Bar Association website, I believe, or I know for certain, the Midwest Carolines website, the Ohio Hospital Association website. I would just say from a reputable website. And a lot of office supply stores have them as well.
Not a question, just a comment. I ran into it a lot when I was at Mercy. Sometimes an attorney will combine those, or try to combine those forms, and that can get really confusing. Because they'll try to put a durable power of attorney with a financial power of attorney or with a will, and it makes it a little bit confusing if they're not separate documents.
Yes, I agree. Any questions?
Yeah, I don't have anything to say except thank you very much. I really appreciate you coming. I'm sure you answered a lot of questions. And I'm sure that if there are people here who have more, you can write them down, we'll submit them, we can write them down and answer them now. They'll probably be here for a few seconds after we conclude, so if you want to ask them something personally, I think that's fine too. But thank you very much. It was very
I had it.
And that's it.
Star.
Yeah.
Say.